So this is rehabilitation considerations for the treatment of neurogenic TOS and rock climbers. We're going to dive in. We got a lot of stuff to discuss. So Jared already introduced me. I'm TH. This is actually career number two. My career number one was in professional ceramic arts. I did that production pottery in the warehouse, very manual labor intensive, um, for about 4 years before going to PT school. And then graduated with PT school in 2020. I've been climbing since 2012, so way back when I was in college. And otherwise, own and run Mend and Send, which is a climbing focused cash practice at Big Island Bouldering in Minnesota. We actually have climbers here. We have quite a few of them, believe it or not, in the Midwest. And then I also work at Motion St. Paul. I'm there one day a week. I also mostly treat rock climbers there, but elbow, wrist, and hand, and that kind of thing as well. So this is actually something that's personal to me because I had thoracic outlet syndrome for a long time prior to PT school. I was working at this production pottery facility. I would go climb afterwards at a bouldering gym. I had bilateral, very deep, aching pain. I could only describe it as this very diffuse ache down my triceps on both sides. I went to a PT, diagnosed it as tricep tendinopathy. Rehab didn't change symptoms. Tricep activation didn't change my symptoms. Like I could do tricep stuff all day with no pain. Generally, it would happen mostly when I was after a day of work, I'd be climbing. I would, especially over the course of the session, it would worsen. I would let go of the climbing wall, and then that's when all of my symptoms would happen. So it was actually when I would release, which was really confusing at the time. And now it makes a lot more sense. And then in PT school, I was positive for every single test, every single special test for thoracic outlet syndrome. And especially during the supraclavicular compression test. We didn't learn about that in PT school. I learned about it later and did it on myself and was like, there's my symptoms. There all of them are. I thankfully have had full resolution of symptoms for the last 6 years. Sometimes it pops up in very small ways, but thankfully it's very manageable at this time. So I'm psyched to jump into this with y'all. I mean, this is free. Nothing disclosed. I'm not trying to, sell anything here. I'm way too passionate about this topic. So we're gonna die. I really had to edit this down. Here are these objectives that I'm hoping to cover with you all today. So we have explaining the thoracic outlet syndrome types and relevant anatomy. So we'll dive into that. Identify presentations and clinical exam findings of thoracic outlet syndrome. Understand current concepts for TOS treatment. So this first third, or I guess first three objectives, this is a lot of what we currently have in literature. A lot of things that you've probably learned in PT school or will learn in PT school if you're looking to go to PT school. So things that are overall overview. And then 4 and 5, summarize clinical pearls for additional exam considerations, and then outline additional treatment considerations and strategies. So this is where we're going to get into the weeds a little bit more about what I've found, how we can kind of take this research that's really difficult to kind of parse through, and weave a pathway of helping people get better who have this. So we're going to dive into TOS types and relevant anatomy. So first off, why does this matter? I mean, I'm clearly passionate about it, but why does it matter for treating patients? Currently, what we have in the research is between 3 and 80 and 100,000 people in the general population, and overhead athletes pose a higher risk of developing TOS over time. We have huge limitations in understanding there's a diagnosis, or this is a diagnosis of exclusion. We'll talk about diagnostic criteria. It's very easily misdiagnosed, can be chronic or disabling for months to years, like it was for me. But if it's caught, up to 95% of patients can receive full resolution of symptoms. Data here is limited, though. Again, if it's hard to catch, it's hard to really track and know how prevalent it is. But clinically, for me, a lot of the patients that I've treated with this were misdiagnosed and failed prior PT. Some people had gone multiple years of seeing physical therapists, and they kind of would talk about TOS as sort of this like maybe it's thoracic outlet syndrome, and then sort of push it off to the side. So I really wanted to dig deeper here. So what is thoracic outlet syndrome? From a broad view here, it's thought of to be a compromise of blood vessels or the brachial plexus at one or more sites between the base of the neck and the axilla. There are three main sites of compromise. There's the scalene triangle, so the brachial plexus is coming between the scalene muscles here. We then have the costoclavicular space, so the space between the clavicle and the ribs, which is where the brachial plexus and subclavian artery and vein are traveling, as well as they continue to go underneath the pectoralis minor. So still going through this space. So there's sort of a three-part tunnel here. As far as relevant bony anatomy, we kind of covered in the last slide here, but just to really pinpoint it. So it's the space between the clavicle and the ribs. The floor of this tunnel of the outlet is the ribs number 1 and 2, and the ceiling is the clavicle and indirectly the scapula, because the clavicle is going to follow where the scapula goes. Since the clavicle is the only bony connection that the scapula has to the rest of the body, the scapula is going to dictate where that clavicle goes. So I didn't take a great picture of this, but if you ever go into one of your anatomy apps and just look down on it, and a lot of us already know this, that it's the scapula and the clavicle are form fitted to the rib cage. So you can get this really strong sense of stability there, especially if you lock those together. We'll talk a lot about those mechanisms later. As far as relevant muscular anatomy, the big ones that are talked about are scalenes, proximity to the neurovascular bundle, that scalene triangle where the brachial plexus runs through, as well as pectoralis minor, which is the ceiling over the bundle that's there. Latissimus is indirectly involved in this, or at least I'm suspicious of that. So we'll get into that a little bit later when we kind of dive into the weeds. But as far as the research that we have, the big ones that are talked about are scalenes and pectoralis minor. And then relevant neurovascular anatomy, what's actually getting compromised in this area. So we talked about it on the first slide earlier, but we have the subclavian artery, the subclavian vein, and the brachial plexus as they travel through that area. So, because there are multiple structures that can get affected here, there are multiple types of thoracic outlet syndrome, depending on what's affected. They can vary quite a lot in presentation. So these are broad overviews of these, and we'll dive into these in a little bit. So there's neurogenic, which is by far the most common. That's the vast majority of what this talk is, because it's what I see clinically. It's what is the most common version of thoracic outlet syndrome, which is compression of the brachial plexus, highlight the scalene triangle or pectoralis minor space. This is 90 to 95% of all TOS cases. We then have arterial, which is compression of the subclavian artery, but it's not considered present or diagnostic unless we're actually seeing ischemia or compression or injury to the artery. And that's actually present in exam. So we'll look at some photos of that in a second, as well as venous, which is compression to the subclavian vein. In 10 to 20% of these cases, so venous thoracic outlet syndrome cases, a DVT can occur, leading to Paget-Schroeder syndrome, which is an urgent referral. I thankfully have never seen one of these in clinic, but if you do, it's pretty obvious. We'll take a look here. So with neurogenic thoracic outlet syndrome, this is what we've talked about earlier, compression of the brachial plexus. So this is where the actual neural bundle is getting compressed in that space. Then we have arterial, which is where the artery is getting compressed. So here you can actually see that this person's skin is degenerating at their fingertips because of lack of blood flow to the area. Okay. Then we also have venous here, where this is a very obvious case of this. It's a compression of the subclavian vein. Red flag here, so you can especially see with her left arm, or perhaps right arm if it's in a mirror, right there. It's swollen, it's discolored, so that's an immediate referral for us. For overhead athletes in thoracic outlet syndrome, we're at slightly higher risk. There's a little bit of evidence on this, but again, data is really limited as far as how often we're seeing this. There's no literature I could actually find that investigates this, but I tend to see thoracic outlet syndrome commonly alongside people who are higher on the Batten scale. I'd love to see this studied. Maybe I'll do it. But we'll dive into potential hypotheses for this later, but this is something I tend to see side by side. So that's the TOS types. We're going to talk about presentations and clinical exam findings, things to look for, especially when someone's coming into the clinic, if you're concerned about this. So how do we diagnose TOS? This is a great question, and I wish there was a clear answer. There is not, and we'll parse through this here. So thoracic outlet syndrome's shape-shifting nature makes it very easy to miss and thus difficult to research. Thus, this is largely considered a diagnosis of exclusion. We're going to go down the rabbit hole together. So this is neurogenic thoracic outlet syndrome clinical presentation overview. So from here on out, we're mostly talking about neurogenic thoracic outlet syndrome. So with subjective, there's enormous variability. We'll jump into these more specifically here. Certain things to listen for. With objective, very few things are actually diagnostic, but they can help paint a clinical picture, as well as special tests. You'll see here that it's kind of a nightmare, and we'll talk about it. They have their place, but as far as the research that's been done on it, it doesn't hold your hand. So first, patient-reported outcome measures here. I mostly use the Quick Dash. There are some others that are mentioned in the literature here that were new to me, the cervical brachial symptom questionnaire, as well as the SF-12. These, I have some other measures that I give people as far as confidence and those kinds of things that more specifically measure rock climbing. This is what's in the research. So here's a great list that I found on common NTOS symptoms and descriptions, which can really just show you how broad this can be. So we'll go down these briefly. Pain localized to the neck, shoulder, arm, or hand. A lot of things can be that. How about tingling or numbness in the arm or hand? A lot of things can be that. Increased symptoms when the arm is raised. A lot of things in the shoulder could be creating problems there. Localized supraclavicular or subcoracoid tenderness, that's a little bit more specific to this area, especially considering the scalene triangle and the pectoralis minor and where that attaches. The positive elevated arm stress test or Roos test, right? We'll get into all these later. Reproduction of symptoms within 3 minutes of arm elevation. Funny enough, I've actually seen in the research that it says a positive it's considered positive if the person's arms get heavy after 3 minutes. And I don't know about y'all, but I'm pretty sure anybody's arms would feel heavy after that. And then weakness, decreased strength in the affected upper extremity. A lot of reasons that can happen. Changes to skin color or temperature in the affected limb. That's definitely something more for me to listen for if they're talking about like it's cold or they're noticing that, skin color is changing. And then occipital headache. Again, a lot of things that can cause that. Other things to listen for, this is more based on my clinical practice and especially treating rock climbers here. So pain descriptors being aching, throbbing, diffuse, or difficult to find. I'll often ask people like, can you pinpoint this? Like, can you dig in and find it? If you're having pain, and that was a big thing for me when I was dealing with this, is I had this pain shooting down my tricep and I could not find it. I was going anywhere to find any kind of trigger point that I could release. I wasn't able to find it. As far as irritability, this is often random, happening sometimes and not others. Some climbing sessions are fine, other climbing sessions are terrible. Worsens over the climbing session usually, but not always. And then, but the big thing I'm listening for is that the intensity of the session and the intensity of the symptoms aren't well correlated. It's very hard for them to like know what's going to set it off. Sometimes it's the day afterwards they feel it. Sometimes it grows over the course of the session. It can really change quite a lot. Other findings, hands falling asleep more regularly or one side's falling asleep while they're sleeping or even just while they're, hanging out doing stuff. Again, that can be caused by other things too. Cubital tunnel syndrome, for example. Limb heaviness or power down is something I've had a lot of people mention. It's just like, I just can't get this to activate over the course of a climbing session. And I recently had an exacerbation of my TOS when I was doing a cross move on slopers over and over again. And I woke up the next day and was like, oh my goodness, I had pain going down both of my arms, the whole 9 yards that was getting worse when I was climbing. And especially at the end of a climbing session when it was really upset, I couldn't hold my arm in scaption for more than about 3 to 4 seconds, and I was visibly shaking and had to bring it back down. So this feeling of like the whole limb is just getting like I just can't get power. This can sometimes even present with finger strength testing as well. Dynamometry, we'll get into that stuff later. And then work, sedentary versus active. That's more for me to think about, okay, if they're sitting at a desk 8 hours a day, we got to talk about some other strategies for this and things that they can do. But these are the things that I'm really listening for when I'm seeing people for this. I'm not going to go through all of these, but this is more for your reference. You can have access to these slides. But remembering to clear the neck, that's a big one. There's huge overlap, like we suggested. Huge list of common misdiagnoses. Here are all of them. There are more. These are just the ones that I saw in the literature and ones that I've seen clinically. And here's the more definitive clinical criteria for diagnosis that I could find, which is that you need to have 3 or more present. The first 3 are more specific to physical therapists if you're kind of frontline conservative management treatment, because we can't do the fourth one. The first one is signs and symptoms consistent with thoracic outlet pathology, including pain or tenderness. Great. If it looks like TOS, it might be TOS, but signs and symptoms consistent with central nerve compression. So it kind of looks like cervical radiculopathy. And then 3, lack of other pathologies from which the presentation could arise. And this is really important. We'll get into this. But that pretty much means that if something else exists alongside TOS, it can't be TOS. It has to be this other thing based on this framework. The last one is a positive scalene muscle test injection. So we'll dive into this a little bit. But if you're finding on your exam that those first 3 things are like, I think this is TOS, I don't think it's anything else, and it looks like it's consistent along a myotomal or dermatomal pattern, might be TOS, or likely is. So This is just a reminder of the cervical radiculopathy cluster because I have seen many cases where it's misdiagnosed as cervical radiculopathy, then they're sent to me, and they are negative for all of these. Greater than or equal to or greater than three of the four of positive. There's some other numbers around this as well, with the median nerve bias being a big one that you'd be wanting to look for. But with Sperling's, ipsilateral rotation, turning your head towards the side that's otherwise a problem, is less than 60 degrees, relief with distraction, and then upper limb neural tension testing with the median bias here. So, as far as objective findings, and then the asterisks are the ones that have actually been correlated with thoracic outlet syndrome in literature. And you'll notice there aren't a whole lot of asterisks out there. But for strength, hand dynamometry, you can test as well as internal and external rotation. You can do this. They mentioned to do it isokinetically. I don't have access to a machine like that, so I use a Tyndec with isometric testing. Scaption, rhomboids, middle, lower trapezius, like manual muscle testing. Range of motion, I'll sometimes look at pec minor length, pec major length, latissimus length. But honestly, because a lot of the people that I'm seeing are hypermobile, this isn't really going to tell me a whole lot anyway. And then posture, there's no correlation in the literature here as far as like we get the posture better and these symptoms go away. But it's still something that I look at, something that I'm paying attention to, paint a clinical picture, as well as scapular mechanics. What is the scapula doing? How is it moving? Again, no research to actually that's supporting that we should be looking at this really specifically. But we'll get into this really a lot more a little bit later on. But at the very minimum, these are the things that I will kind of look for on the front end. Here are the special tests. I'm not going to go through these. Jared actually has an amazing blog post on his website right now that has another clinician that goes through every single one of these tests with videos. So a lot of these should otherwise be review for you if you've been to PT school or if you covered this. But I had a lot of fun taking photos with my friend on these, and our faces got sillier and sillier, such as with this one. So there you go. You can get a nice zoom in on that. There we go. He's having some issues. There's one problem with all of these tests, though, which is that not a single one currently has consistent psychometrics, sensitivity, or specificity in the research. Not one. Um, so you can use all these. It's great. Again, it can help paint a clinical picture, but as far as having these rule in or out, we just don't have that data. What we have is that clinical diagnosis cluster that we talked about of like, it looks like TOS, it looks like cervical radiculopathy, but it's not cervical radiculopathy or anything else. And if you're confused and lost, great. I am too. So thanks for being here for it. So the big picture, kind of backing away from all of this, is that thoracic outlet syndrome is more about questions than answers. I mean, clearly I am here presenting this very skeptical voice, but such as if TOS is a diagnosis of exclusion, what happens if it's happening alongside something else? How important is diagnosing it if it's so vague as a diagnosis anyway, if it's so hard to pin down? And if there are no exam findings that strongly correlate with the diagnosis, how do we objectively track that it's getting better? Even though the special tests have such poor psychometrics, might there still be value in using them due to the positional similarities of climbing or just looking at all of this? I think so. I think they're tracking this in retrospect after I was putting all these slides together. I don't have a great way to objectively track this. It's based on a lot of subjective reportings and just giving people a lot of tools and seeing if they can see some changes over time. But I hardly see this on objectively on exam. Sometimes I'll retest, I'll retest those positions and see what pulse is and that kind of thing. But, you know, um, so much of it is just based on your interaction with the patient and following with them over time. But personally, so I approach this as being varying levels of suspicious of its presence, as opposed to ruling it in or out definitively. In climbing, I'm suspicious that it may arise from certain strategies used for pulling on holds, and we'll talk about those biomechanics later. And I try to bring my patients into my thinking. Show it's messy. Like, I don't know. I don't know what's going on. This is really confusing, and it's different in everybody. So, but let's try some things and see if any of these help you find a little bit more of a pattern in this and have some control. So now we'll get into treatment, the specific treatments for thoracic outlet syndrome as it's defined in the literature, what we have access to. So PT versus surgery. I know surgeons don't use scissors, but I had fun taking this picture here. The outcomes range wildly with PT. I mean, 39 to 95%, depending on where you read. There are some non-surgical options, scalene or pec minor, Botox, that show some good outcomes. And then there are surgical options. Hilariously, in the literature, they call this a what did they call it? They called it like a costoclavicular decompression, which if you're thinking, subacromial decompression, you're thinking like, okay, they're just gonna like clean it up a little bit in there. With this, they're taking out the first rib. That's a decompression, as well as taking your scalene out. They're just gonna go in there and snip it, and that's a decompression. No big deal. As well as a pectoralis minor release, going in there and snipping it. If people are failing rehab, this has been shown to have some good outcomes. But man, I like my first rib, so I'm going to keep mine in there personally. And I think a lot of my patients like their first rib too. As far as PT philosophy and approach, what exercises are we doing and why? There is even with this a huge range. There's a great article I found by Lou et al. That's the bottom left one here, where they actually looked at all of these systematic reviews of exercise that's being performed for neurogenic thoracic outlet syndrome. And they also had a column that talked about their justification for doing so and why they were doing it, which was great. And there were a ton of conflicting reasons why people were doing things. One group is like scapula down, other groups doing scapula up, and that's all we're doing. And everybody got better. Everyone got better. Um, uh, and most of these, it was like, regardless of the approach or the philosophy, they're doing exercise, they got better. So even conflicting approaches led to positive outcomes. This really wrecked my brain to take this photo with one shoulder up and one shoulder down. That was really hard for me. So anyway, I'm proud of that. And then as far as specific approaches, they addressed posture, breathing, scapular elevation, depression, scapular mechanics, nerve glides, general strengthening, joint mobilizations, manipulations, dry needling. But the one treatment that is supported by solid evidence, literally the one in the article, current clinical concepts down there, that has an A next to it is exercise. Nothing else. Everything else was B or C as far as the quality of evidence supporting it. But exercise is well supported here. So key takeaway, the authors recommend a biopsychosocial approach because exercise works. We'll talk a little bit more too. And then here's another one. If you are suspicious of neurogenic thoracic outlet syndrome, exercise for it will make it better. So the worst thing that can happen is if you're just not catching it, if it's presenting as something else, or if it's possible this is happening, even if you're not sure, if you're looking up the chain and treating the shoulder, the symptoms are probably going to get better, which is great. So from my standpoint, also, generally, I try to look up the chain regardless with climbers being a closed chain sport. I try to look up the chain regardless of what I'm seeing them for. So, um, this can give you, for some people it might be like the floor is ripped out from underneath you of like, I don't know what to do with any of this. Nothing means anything. And yeah, I've been there many, many times. But from my standpoint, this gives you a lot of room for experimentation and curiosity. If you're kind of thinking like, okay, well, we just can be confident that this works if I'm suspicious of it. So we can dive a little bit deeper into this philosophically and find your rabbit holes that keep you psyched. So this is now summarizing clinical pearls for additional exam considerations. So this is kind of more of the meat of what I'm pumped about. I like it all, but this is really what's fun. So additional exam considerations that I've kind of landed on. And again, I, if some of you are treating thoracic outlet syndrome, you might arrive to completely different conclusions, and that's fine because for all of us, if we're doing exercise with people, they're going to get better. So this is what I've landed on. It may not make sense or align with you. That's totally fine. I might, these slides might be completely different in 5 years, and I might be landing on a totally different area, but this is what's exciting me clinically right now. So I want to talk about latissimus involvement in scapular positioning. Here's another, little FYI. The landed head is muddy. Since there is little guidance, content to come is based more personal clinical experience. You get it. Everything that I just said. I'm ahead of my own slides. This is great. So I want to talk about latissimus a little bit because the actions of the latissimus, especially what we're seeing in research, how it's talked about, even on Physiopedia, it specifically talks about it performing extension, adduction, and an internal rotation of the glenohumeral joint. Then, if we think about scapular depressors, we're typically thinking lower trapezius fibers, pectoralis minor, and then inferior fibers of the serratus anterior. Okay, especially because they have an inferior angle from posterior to anterior here. So those three. But what happens if the latissimus contracts when there is an abduction moment? So if we're thinking about physics, and we'll get into physics here in a little bit, and dive deeper into this. Um, so if you've got a water bottle or something that you can hold on to, you can just hold the weight of your arm because that's even a demand. But if you hold your arm out to the side like this, okay, in kind of a scaption flexion, and you just palpate and grab onto your latissimus, okay, so right now there's an abduction moment, or scaption moment. So deltoids working, supraspinatus is working, upper trapezius, all that good stuff. But if you're here and then you depress the scapula, if you pull your scapula down, may not happen for everyone, but my latissimus engages. Why would the latissimus engage? It is a shoulder extensor and adductor, right? And internal rotator. I'm not performing internal rotation. I'm not performing adduction. I'm not performing extension. But here, the scapula is actually performing scapular depression. So we're going to dig into this a little bit, or at least I'm suspicious of this. It might not happen for everyone. But why would we want depression? Let's even talk about that as far as like a strategy for climbing and for shoulder positioning. So we talked about the perfect fit, the clavicle and the scapula plus the rib cage is a perfect fit. Perfect fit equals stability. You can just lock that thing down. It ain't going to move. Okay. Stability means that you have reliable joints during the demanding act of climbing, which may explain why I tend to see this alongside hypermobility. Again, I would love to see some research here, but I could not find anything about it. But especially if someone's unstable, or if they're hypermobile and they're craving stability in their shoulder, this might be a really nice way to get it at the cost of compressing some of the structures in that space. Why would we not want it? So, kind of like I alluded to, thoracic outlet syndrome is related to irritation of the structures in the area. So, what happens to the thoracic, excuse me, what happens to the thoracic outlet when the clavicle approaches the ribs? What happens to the nerves? What muscles are we actually using? Right? Is this just pectoralis minor and lower trapezius and the inferior fibers of the serratus anterior? Or are we getting other things involved, like the latissimus, such as in this circumstance, right? But again, big asterisk. We know the philosophy of the treatment doesn't matter. So this is just my philosophy. It's what I'm landing on here, like at least the questions that I'm asking. But at the end of the day, exercise is going to help people. But still, I'm the kind of guy that likes to dig deep. So therefore, from my standpoint, down and back might not always be the answer, especially if we're suspicious that the latissimus can be assisting in this and performing that scapular depression. So here's me trying to make my scalenes pop out as much as possible on the bottom left, which was actually kind of straining, and I was getting a little bit of symptoms down my tricep with this, as opposed to being in a shrugged position. So in fact, shrugging during load might actually have some benefits. So I want to, again, if we're thinking about like, okay, this is so muddy, like I gotta cling to something. I gotta find some like avenue of truth through all of this, which is where I was for so long because I was like, this is just not guiding me. It's doing the opposite. So, for me, what I anchored myself to was biomechanics and an understanding of physics. So I want to just remind everyone of torque here. Um, Moment arms. Moment arms are the perpendicular distance from the line of action of a force and the center of an object's rotation. So in other words, if a force vector is further away from a joint, right, the greater the demand of the muscles at that joint. So here are some nice examples of that, where in this first one here, the line of action is very, very close to my elbow and my shoulder, so this is not hard. Now suddenly I'm getting a little bit more of a contraction of elbow flexors as well as shoulder flexors because that line of action is coming anteriorly. And if I bring it really anteriorly, I'm still getting a line of action at the elbow as well as a line of action at the shoulder. And I took this photo and was like, holy thoracic kyphosis, big guy. Somebody's got to manip your spine. Anyway, this is only about gravity, but what about complex climbing forces? It's not just about gravity. We've got some forces where it's, compression is forces going inwards, that where you're resisting gravity, or Gaston's going out where it's drop knees, all of this stuff. So when I started kind of thinking about this and investigating, I'm like, what are ways that we could actually visualize forces that aren't just about gravity? Rings and TRX are fantastic because we literally have a visual representation of that force vector that you are applying on this. So if we're thinking about climbing, the way that I'll have people imagine force vectors when they're climbing is I'm like, where would your hand dry fire to if you let go right now under load? And that's the force vector, the direction of the force vector they're applying. So it's a great tool because you can compare that line to how it's intersecting the body and the shoulder and the elbow and so on. We can imagine moment arms as they interact with the upper body in the sagittal and transverse planes. So let's get into it. So if, say, we're going to exaggerate this, the scapula is down. We're depressing it as hard as we possibly can. And with this, we're kind of bending a little bit more at the elbow. So if the body and the hand are in a given position, this line has a force vector closer to the shoulder and further from the elbow, which means there's greater demand at the elbow targeting the elbow flexors and lesser of a demand at the shoulder targeting the shoulder extensors. If that line is going straight through the shoulder, there's not a whole lot of demand for the muscles of the glenohumeral joint to fire. But a lot of people feel this in their lats and they're like, oh my gosh, like I'm cranking down there. I can feel my lat performing this, you know. But if it doesn't have a demand, then why is it activating? But maybe it's acting more as a scapular depressor and not a shoulder adductor or extensor in this circumstance. Maybe. Again, study anyone? Does somebody want to research this stuff? That has more resources to research than I do. So then if we look at sagittal scapula up, so getting back to shrugging, in a case for shrugging, if we wanted to do that, if the body and hand are in that same given position, but the scapula goes up, there is lesser demand at the elbow, targeting the elbow flexors, and there's a greater demand at the shoulder, targeting the shoulder extensors. So even if people are like, I can't, like my lat's not engaging like when I'm doing it like this, we might actually be getting a more effective contraction that's actually a result of the force vector they're applying, not just the scapula going into depression. And then transverse, we can look at it from above or behind. I tried taking a photo from behind and that didn't work, so I had my buddy stand on a box and take a picture of me. But if the elbow is chicken winging out to the side, the force vector is medial to the elbow. Thus, there is a demand for shoulder for internal rotation, as opposed to if that force vector is in line with their elbow, there's more of an equal demand on the shoulder internal and external rotators. And in my experience, this gets a lot of the parascapular musculature firing really, really well. So let's bring this all back to exam. If we take this kind of this biomechanical approach here of thinking about physics and lats as a potential scapular depressor, we can bring this back in. Could scapular position give us insight into a patient's ability to produce force? Again, in research, scapular position doesn't matter, but this is the rabbit hole I'm going down. So thanks for joining me on it. So what I'll often ask them to do is just row without cues. I'll have them do a single arm row or a double arm row, if their symptoms are really flared up, and I just want to watch and see how they move. So I'm really paying attention to like how are they moving on one side versus the other? Where is the elbow? Where is the ring compared to the other one? How are they wanting to move that through space on one side versus the other? Just to kind of see what systems they want to use, what kind of neural pathways they have as far as motor learning goes. So I like to video side to side sometimes if I have the time. And then looking for scap depression or elevation, force vector being, elbow or shoulder based, and then internal versus neutral, and so on, right? So just get some information of movement analysis here. And then sometimes on exam two, I'll even palpate and look to see like, when they're just performing abduction or flexion where we shouldn't be having much of a latissimus contraction. What's the latissimus doing? Is it contracting? And then of course, my hands are on people, so that might actually be encouraging the latissimus to contract. So I'm not even sure if that's, telling me what I want it to be telling me. Um, but I'll also do this through manual muscle testing or exercise and looking to see like what's the latissimus doing, what's the shoulder doing, and so on. Again, this is not diagnostic, but can help paint a clinical picture and just ways that I tend to look at this. Scapula position versus with like manual muscle testing or dynamometry. There is a study that came out that another professor pointed me towards that shows that there is change in shoulder strength depending on if the shoulder is in protraction or retraction. Um, so this is something that I play with here, which is I tend to try external, internal rotation and abduction in depression or elevation. And I'll do it side to side. Often what I'll see is that if somebody's symptomatic on one side, that they're really willing to like, it doesn't matter where the shoulder blade is, they're solid. They're like, I know how to contract all this stuff. And then on the other side, it might just be like they get into elevation and they're like, I have no idea what to do here. Like I have no idea how to resist you. So I would love more research here, especially in that pretty much that same article, but in depression and elevation. And then scaling hypertrophy is something that, people often talk about. And so for me asking a lot of questions, I'm like, why would the scalenes become hypertrophic? Why would that happen? You know? Um, but then I started thinking about this bony lock that we have, where we have this first and second rib that's getting pulled up by the scalenes, as well as this clavicle and scapula that's getting pulled down by all the muscles we mentioned, potentially latissimus as well. So we're kind of thinking okay, this is sort of like a tug of war battle between the scalenes and the latissimus, and I know who's going to win that battle. The latissimus, obviously. So with the scalenes, it's like, of course they're going to get huge, man, if they're fighting against the latissimus. And if people are really relying on this scapular depression all the time, um, yeah, scalene's no wonder, and upper trapezius too. We'll otherwise get like a ton of depression, and you're putting that upper trapezius on stretch. If that trapezius is co-contracting under that stretch load, like yeah, that's not going to feel good over time. Um, so here are some other climbing movement considerations too, for I'm watching people climb. So I work in a climbing gym, so I'm really fortunate in that I can watch people climb on exam. For their eval, we'll go and climb for 10, 15 minutes at the end of it, just so I can kind of watch them move and see what's normal for them. And this is again, I'm kind of thinking I've already done my exam. I typically will do my exam first and then watch them move later. Yeah, some people like it reversed. And for me, I'm kind of like, okay, I've seen everything on exam. How do they move normally? Like, what are they doing, before we even get into exercise? And so I'm looking to see like, where does their scapula like to live? Is it elevated? Is it depressed? Is it rigid? Is it mobile? Is it moving? Is it stuck in one spot the whole time? Are the hands towards midline? Again, if we're thinking about that ring and we're that pulling towards midline, if we're drop kneeing and then pulling towards midline, like, that suddenly doesn't have a whole lot of reason for the shoulder external rotators or parascapular muscles to contract, right? So this can give you a ton of information as far as like, are they doing it more on one side versus the other? Are they drop kneeing every time on one hand versus the other one? Are their hands moving really fast on one side compared to the other side, even on warm-ups, which could be suggestive of like they're not comfortable hanging out on the pulling arm for an extended period. So again, there are no hard rules with this, but these can give direction for climbing drills to incorporate into treatment, which we'll talk about in the treatment section next. So you can turn this into treatment here, suggesting this, I guess. Which is that, again, I'm playing with this stuff. So I'm like, if I'm noticing something that someone's doing and I'm kind of like, hey, I'm kind of seeing this. Let's go down this and mess with this a little bit and just see what this feels like for you. I've been noticing that scapula wants to really live down the whole time. Can we try climbing where it's up a little bit more? Like do it on both sides and climb really statically with it up and just see what they feel like. And a lot of the times people are like, I don't know where my shoulder blade is. This feels really foreign to me. I don't know what the heck is happening. Only on this side, but not on this side. So just play with it. This is the kind of stuff I'm landing on. I'm sure y'all have great climbing drills that you really appreciate. And then I'm looking at spinal motion too. Are they rigid versus flexible? Are they really like cranking down on one side? So in this upper left photo of me right there, if we're thinking of a latissimus, not just at the shoulder, but especially its connection points between the glenohumeral joint and the thoracolumbar fascia, and it's trying to pull those together. If people are really cranking down on that side and side bending towards the pulling side, as well as depressing the scapula. It's like, wow, that lat is hella engaged. It's super, super engaged, which may not be a bad thing, and that might be not be contributing to their symptoms at all. Versus if they're a little bit more square, is their spine like really bendy? Are they staying really square and neutral? And have them try the opposite thing. If you're seeing something that's really that's really standing out as a repetitive strategy that they're using when they're climbing, have them try the other thing. So the big takeaways here from this section, scapular depression or scapular positioning, the pros of that is you can get a really, really stable joint, right? But the cons that it may interact negatively with the thoracic outlet and the latissimus might actually be more involved than we think it is as far as what it's doing to the shoulder. Or I'm suspicious of this at least. And then with biomechanics, force vectors can matter a ton as far as like how people are navigating that and what their strategies are for doing so. And if you're, excuse me, showing this to people, and have videos and can kind of draw some things out, you can kind of explain like, this is at the very minimum, your body really wants to do this. Let's mess with doing this for a little while and see what happens. And then with climbing tendencies, watching someone climb is crucial. So sometimes even if people are like doing a consult with me and I'm like, all right, great, we'll get an eval, send me some videos of you climbing, easy stuff, hard stuff, whatever. Have your buddies film you and send it to me, and that can give me some front end information. And then especially visualizing everything we talked about, scapular motion, spinal motion, positioning tendencies, and so on. So then finally, we'll get into the additional treatment considerations and strategies here. So this is really where things get fun. So I'm going to get on a little soapbox here for a second. This is my soapbox slide. Already got on a lot of soapboxes, but I dedicated a slide to this one. So manual therapy, I do manual therapy with my clients, but especially in TOS, I feel like it may muddy the waters. Again, a big reason for this is at least the cases that I tend to see here in my practice is that tracking symptoms are already so difficult. They don't really know what's working. They don't know what's not working. They don't know what's making it worse or better. Some people have very definitive. It's like, this is the thing, and this really is awful. And other people, it's already hard to track. So if I'm also providing a manual intervention for them, and then we can't do test retest anymore because we otherwise, after exercise, then we've otherwise taken away some information that may actually be really helpful for them as far as how to navigate pain and if there are exercises or strategies that they can do that take that pain away from them. So putting the power in the hands of the patient is education is huge for this. And manual therapy has poor evidence in that article that I mentioned earlier. It's a C. So there's not a whole lot there that actually recommends the use of manual therapy. So patient education, I didn't take a photo of me educating somebody, so I put this one on here instead. So, but as we discussed, outcomes for it can be really highly variable, and there are many strategies for shoulder stability. TOS is often the result of a repetitive use of the strategy, not necessarily scapular depression. It can be other funky things that people are doing. Um, but if the body has it once, it may happen again. If we're thinking about thoracic outlet syndrome as being a potential expression of the use of a repetitive strategy, that's something that we want to get into, right? Whether that's posture, repetitive strategy of being here and like hanging out on the desk all day, elbows out to the side and internal rotation, right? That's a strategy. Whether it's good or bad or posture, well, I don't know, but like let's do something else and seeing what happens. And then teaching patients to experiment exactly like this. Track symptoms based on trial of new strategies. So trying to, we'll talk about this in a little bit. I'm getting ahead of myself. So patient education continued. The pain here is rarely, if ever, dangerous. I mean, most people are getting better. It's compression of that area. It can really irritate it, but as far as like true tissue damage, it's pretty rare. Therefore, pain neuroscience education is really important. So I find myself saying things like, TOS pain is like a yellow light, not a red light, right? So like, a hard stop on this unless it's really irritable. It's like if you're having a little bit of pain, that's okay. And then your shoulders may be craving stability, so let's see if we can help it find a new strategy for stability, right? That might not be the only way of doing this. So let's see if we can do it in a different way where you still feel stable, but you might not otherwise be having this trade-off. So we'll get into mobility and posture interventions here. So stretching ideas, these are pretty typical. If we're thinking pectoralis minor. Uh, the big thing here is that I found symptom recreation to actually be okay. It's sometimes things that people are scared of, but when I had mine going, I was really flared up. I did a pec stretch on a foam roller, which I didn't picture here, I guess, but you're on a foam roller and you have weights in your hands and you're holding them on the ground. And my hands got so numb, and I just was like, you know what? Let's just see what happens. And so I just stayed there. And after about 4 or 5 minutes, all of my numbness and tingling was gone. And then I had a whole climbing session was completely pain-free. It was like, whoa, okay, that's wild. But that kind of told me that I was like effectively stretching that muscle. So especially when it comes to doorway stretches, I tend to have people do a low doorway stretch as opposed to a high, especially if people are hyperbobal. I just don't want to piss off the glenohumeral joint, right? So being low with an emphasis on scapular retraction. So really trying to increase the space between that coracoid process at the front of the scapula, as well as the third through fifth rib where it attaches, right? So really trying to increase that space as well as a little bit of elevation. So some active elevation with that. It's kind of an active stretch. It's not super relaxing to kind of get into that. So that pec stretch can otherwise be helpful with that as well. And then human flagpole stretch is what I call this. It looks like you're about to do a human flagpole and you just stand there. So it's not nearly as cool. I've never tried to do a human flagpole. I just do these instead. Safer. So anyway, with this, you're kind of using the inside leg to try to push your hips away. So if we think about the latissimus as performing ipsilateral side bending, as well as scapular depression and all the shoulder things that we talked about, let's do the opposite things. We're going to go into contralateral side bending, abduction all the way across, right? And then really, and scapular elevation. So while I'm there, I'm really teaching people like shrug and try to make a C with your whole spine. And it can help open up that thoracic outlet space. It just feels awesome. I will brush my teeth and do this, and that helps me actually brush my teeth for as much time as I'm supposed to. I don't really stretch the scalenes or the upper trapezius, mainly because, I'm falling on the side of the fence of like, I kind of think they're stretched already. I think we're stretching them, down into this position and then we're loading them. And I think we need to find some ways of chilling them out as opposed to like really stretching. Some people might find great results with that. I haven't personally. So I don't tend to do that. And I've seen decent results just even avoiding that stuff. The big thing here is that stretching can be used as a personal test retest, especially if those muscles are really bearing down and then opening them up. So if someone has a move that's really painful, shouldery move, compression move, undercling, that kind of thing, have them go do the stretch for a full minute and come back and see if it changed anything. It might not, but if it does, it can give that person a sense of control over the situation where they're like, I can change my pain like that. Like I can go over and stretch and it feels way better. So it puts the power in the hands of the patient with that one. As far as posture goes, I also didn't take a picture of this, but it's a lot of like, what it's based pretty obvious based on what we talked about up to this point. So posture correction shows no major correlation with pain and how TOS changes over time. But there's some strategies that I've landed on based on this kind of thinking about where the scapula is, which is very gentle shrugging when seated, kind of up and back. So thinking like along the line of pull of the rhomboids. So I'll give people the cue of like really gently pinch your shirt tag. It should feel like the muscles back there are contracting at like a 1 out of 10. And I have some exercises to help people like really calibrate what that means as opposed to like, flexing absolutely everything. And then elbows under the shoulders. And if people have an adjustable work from home and if they have an adjustable armrest, I'll often encourage them to actually elevate that armrest because then it'll encourage scapular elevation and to see if that helps them. Right. And sometimes it might not for some people. And then scapular proprioception, so helping people like also develop the sense of stability in a new area. So they can't see their scapula, so tactile feedback and surfaces can be really helpful for them to gain some input. So as far as the surfaces for proprioceptive freedom and limited degrees of freedom here, these are some ideas that I've landed on. I do these dowel thigh slides. So you've got this limited range of freedom as far as like where can your hands move? They're going along the plane of your thighs, right? I've got a ton of feedback on my back. I've got my full spine connected to it. And then what you're doing is you're bringing your shoulder blades up and back very gently, keeping your arms straight such that the PVC pipe drags up your thighs and back down. The faster people do this, the more that everything will engage. So much of this is like, I'll encourage people to do it like on the inhale and then on the exhale, just kind of like let it drop. So really trying to encourage them to just let the scapula be mobile in a very fluid, organic, gentle way. Then we have external rotation with the back at the wall. So right after they do these PVC glides, if they have weakness with external rotation, and they almost always do, um, then we'll do these. But if you test retest with external rotation, though, you'll usually be way stronger after doing these anyway. So what's that telling us? Anyway, readiness to contract is usually how I describe it to people. But going up into that position and then learning how to activate there. If they're really having a hard time knowing how to stabilize and contract in scapular elevation, this is a great exercise for them to begin that. Then, as far as rowing motions go, if we're thinking, okay, we want the latissimus to perform glenohumeral extension, internal rotation, adduction, but we don't want it to be a part of scapular motion, then having some visual cues or tactile cues for people to rely on can be really helpful so they can have a cleaner motion with this. So with this, I'll have people do bent over scapular retraction, but then there's a foam roller that's superior to where the weight is. And then they have to retract, but keep the weight in contact with the foam roller the whole time. And if you see their elbow bending, that's the or that's the latissimus trying to get involved, right? Or teres major, whatever other adductors we have that are there. So trying to encourage people like let that arm just hang, like just don't even try to actively extend it, just let it hang. And then all we're trying to do, a lot of tactile feedback for like, this is where I want this to happen. I want the shoulder blade to move here, but this is a nice way for them to feel like they can actually be successful at this at home. As far as strengthening goes, then starting kind of towards midline so they can see their hands before they're getting out into space. They already can't see their scapula and then, can't see their hands. So I really try to limit the degrees of freedom on the front end. So no pyramids where you're closer to midline, pulling out external rotation and then you're going up and then back down in a slightly shrugged position and then really trying to encourage people to be there. Then one of my patients called these crime scenes, but I came up with this one on the ground where you have your feet kind of wide, you have one arm out to the side, you're gently pressing into the floor with the hand, the non-working hand, and both of your feet, which kind of helps lock the torso in place. And then with the working arm, you turn your head away from it. So you can't really get much neck involvement. And then you gently lift your hand off the floor and then slightly use the floor as a guide to go up and down. So this is a helpful way for people to learn really how to like activate external rotators through a really clean plane of abduction here. And then the progression of that being bench elbow slides here. So now you suddenly can load it. You can be in a quadruped position, and then you're gently using the elbow, gently using the bench to go up and down. This is a killer. I've never seen anybody do more than 5 pounds with this. It's extremely difficult, but it can help people really understand how to use the external rotators while in that position. As far as scapular positioning goes too, because the lats can still be involved as far as like trying to anchor everything down. So while they're in a relaxed position, if their arm is right here, I'll ask people, bring your elbow close to you. And if they just try to bring their elbow close to them, that generally will push the scapula into that up and back position and helping clear that open. If people are just really having a hard time with this, I'll also tell them to open their rib cage on this side, almost thinking like we're approaching that human flagpole stretch to just get all of that moving. And then getting more into open chain with this, where you can, the first one here, it's difficult to see the cable, but I'll do cable face pulls with this, where you actually grab the tricep rope, and then you pull it towards you and then push apart such that the little anchor, the metal anchor taps you, not hits you in the forehead. Usually people are like, bam, oh, geez, the first time. So, setting people up for that is good. And then the flies. So I didn't show the starting position, but then I like doing this with one arm at a time with a slightly bent elbow. And you're kind of going up into that upper motion of the bench slide. So I kind of cue people. I'm like, okay, we were doing those bench slides before. That upper position that's right there, that's where we're going to go. But we're going to not do it with the bench. And you're just going up into that position. And I tell people like wrist first, not elbow first. So it's not like elbow and then a whip. It's much more about like lead with the wrist, right? To make sure that we're having shoulder external rotators being active the whole time. As far as pull motions go, same here. So we did the scapular retraction before. Now we can add a row to it. So you're doing the scapular retraction, then you perform the row, bring the weight back to that, and then scapularly protract. So you're separating glenohumeral motion from scapular motion as a way for people to kind of help figure out how to do that and dissociate the lat from doing both things. Then you have ring rows, single arm ring rows. You can cue people depending on like where, where you want their hands to be. If you're really having a hard time getting them out to the sides, I'll actually put a band around their wrists while they're doing it with both arms. So they have to press outwards to really instigate an external rotation moment. And then we have assisted pull-ups with retraction versus depression. So here, what I'll have people do is like if they can get their feet on the ground, I'll just tell people, I'm just like, just bring your shoulder blades towards me. Just bring them straight back, as opposed to like cranking down. So bring your shoulder blades towards me, hold them there while you're performing a pull-up. So that's that first option that's there. And then once they feel really comfortable with that position, especially with overhead pulling, doing so with a jumping to a bar, and you can kind of spread that spectrum out. You can kind of like have them be assisted or like having their feet on the ground and very quickly jumping or very quickly grabbing the bar, but with their feet still down, right? So doing a quick contraction there and getting into that position and doing it in varying degrees of shoulder abduction can be a nice way for them to just learn, like, how do I get stable with an elevated shoulder when I'm doing something that's really hard? And this can be a nice way of helping them do that. And then as far as climbing drills go, we have early drills. Again, I think of this as learning new strategies, not correcting or replacing the old ones. So shrugging during warm-up climbs, square versus drop knees, breathing through climbs. So making sure that they're actually breathing, paying attention to breath holding and that kind of thing. Other considerations, rest day between climbing, no feet cutting on the front end, no symptoms greater than 2 out of 10. So I still do pay attention to that. And then if they have symptoms, attempting stretching or some of their strengthening exercises. I generally find that after people are doing these exercises, they feel really good. They're like, whoa, my shoulder, like my arms feel awesome, like all of this, and then helping them carry that through a climbing session too. Mid-stage drills, flexible scapula. So here I kind of am doing that deconstructed row with the foam roller before. So I'm in protraction. I really think of it, especially with hypermobile people who don't want to let go of that scapula, I will actually cue them to punch their shoulder blade away. So they're still really in control as opposed to letting it go. So punching that shoulder blade away and then performing retraction and then extension as they're pulling through a move. And then skipping holds statically, so as getting their hands further apart on easy holds to just practice being in further positions with an emphasis on scapular positioning. And I didn't get a picture of this, but hands or lava is the one I'll call this one, where I'm trying to get people away from midline. So I'm like, get your hands where you can't see them. So, hands where I can't see them would be a good name for that drill now that I'm saying it out loud. So get your hands to where you can't see them. So really trying to get your hands out of that and get out of midline with your shoulders to really encourage activation of posterior chain. Then late stage drills, 1 foot in retract, 1 foot on, so you get to choose 1 foot for the entire climb. You're otherwise performing really gentle foot cutting for that, with an emphasis on, shoulder, elbow, scapular positioning, and so on, based on what you find on exam. Peter pans and retraction, so where you go for the next hold, you aggressively throw your legs away. You can just dyno between holds if you want to, but with a lot of that, just trying to be under this more aggressive load of helping people learn new strategies for where they need to keep their shoulders. Final thoughts. Wow, we are right on time. That's great. I find myself thinking of neurogenic thoracic outlet syndrome as an abstract expression of how a climber uses a biomechanical strategy repetitively and treating it by helping climbers understand pain and fill out their climbing toolbox, as opposed to a rigid diagnosis of irritated structures that is explained and treated pathoanatomically. And I don't know about you, but I find that first approach a heck of a lot more fun. And that is it. Wow, I feel like I just flew through that. So thanks for bearing with me, everybody.